Welcome to NOAHE Round 6, Session 6. My name is Erin Kerwin, and I'm going to be facilitating this session. So please help join me in welcoming our presenter, Dr. Alton Russell. Dr. Russell is an assistant professor in the McGill School of Population and Global Health and director of the Data-Driven Decision Modeling Lab, or the D3 Mod Lab. Dr. Russell received undergraduate training in industrial engineering and public health at North Carolina State Universities, master's and doctoral training in management science and engineering at Stanford University, and postdoctoral training at the Massachusetts General Hospital Institute for Technology Assessment at Harvard Medical School. So today's topic is informing targeted public health measures with data-driven decision modeling. Before we begin, I'm going to go over some about event housekeeping. Participants will be muted throughout the webinar. To submit questions during the webinar, please use the Q&A function. And this is a friendly reminder that the Q&A function is different from the chat function, and you can use it at any time during the presentation while you think of a question. The Q&A answering your questions will be facilitated during the final 20 minutes of the webinar. So thanks again for joining us, and I will now hand over to Dr. Russell.
Thank you so much, Erin, for the introduction, and thank you to Nicole also for helping to organize. I'm going to share my screen. Please let me know if you cannot see it. But as Nicole said, I'll be talking about informing targeted public health measures with data-driven decision modeling. And a big research area that I've started to get into and want to get into more is trying to reflect heterogeneity in decision modeling. So in traditional decision-analytic modeling, the models used for economic evaluations often focus on the aggregate or the average outcome for a population. But increasingly, people are realizing that it's important that we understand the distributional outcomes across heterogeneous population. And I think interest in understanding distributional outcomes is a result of this focus on personalized medicine and trying to target interventions better. But also a result of the recognition that we need to be considering equity in our decision-making process. And in order to inform decision makers who are thinking about equity, we need to have models that understand the equity implications of policies. And then also another byproduct of this is that when you do a better job of modeling the distributional outcomes or heterogeneity in outcomes, it can also improve estimation of the overall outcome. So you kind of end up getting the original goal, you achieve it more almost without even meaning to. So my research group at McGill, I've called the Data-Driven Decision Modeling Lab, or D3 Mod. So we focus on decision analysis to inform effective, equitable, and efficient health policy. And we use the more traditional modeling methods used for decision analytic modeling, like simulation, compartmental models with differential equations or optimization, but we also integrate data-driven methods like machine learning and Bayesian statistic. And we work in a number of different application areas, but today I'm going to focus more on managing blood donors and opioid harms reduction. So I'm going to focus on two main research areas in more detail, which is tailoring policies to manage the risk of iron deficiency in repeat blood donors. The second is targeting overdose prevention for patients receiving prescription opioids. And then I'll talk very briefly about more emerging research areas. And I'll stop after each to see if there's any questions, if that works. But feel free to interrupt if there's a clarifying question along the way. So this first project is related to managing iron deficiency in blood donors and was supported by Vitalant, which is one of the bigger blood collectors in the United States, and the foundation of the Association for the Advancement of Blood and Biotherapies. So in the United States and in Canada, there are two safety measures for preventing iron deficiency in blood donors. There's a pre-donation fingerstick hemoglobin test with a threshold. So if your hemoglobin is too low, you can't donate blood on that day. And there's a minimum interdonation interval, which is 8 weeks or 56 days in the United States. In Canada, it's a little bit longer, and it's also longer for women versus men. So a lot of countries do have a longer interdonation interval for women versus men, but the United States does not. But despite these two safeguards, we still have issues. First of all, hemoglobin deferrals, while they're a safety measure, they're also not a most desirable outcome because it wastes the time of the donation of the collection staff and the donor. And donors who are deferred for low hemoglobin are less likely to come back in the future than someone who completes a donation. But despite the hemoglobin test, because hemoglobin is an imprecise and lagging proxy for your true iron stores, a fair number of our repeat donors are donors who have low or absent underlying iron stores despite having sufficient hemoglobin. And there's a few different kind of additional interventions people have been looking at, so we can lengthen the minimum interval, either uniform or sex-based like Canada has, which allows more time for iron recovery, but it can reduce donation frequency so we don't get as much blood. And by the way, repeat donors supply over 60% of the blood supply in the United States, and I think it's similar in Canada as well. We can use supplemental iron, so we can either give people iron supplements or give them a voucher to get iron supplements, which is good because it can hasten the time for iron recovery without changing the donation frequency. But there are some costs associated, and there's the potential for side effects, which some blood centers have not implemented due to the liability risk if someone has some severe gastrointestinal distress, which is a rare side effect of iron supplementation. So ferritin is a more direct measure of your iron stores. And so some blood centers have implemented ferritin testing, but it's not available as a point of care test like hemoglobin is. So we can't, do a ferritin test and that same day have you give a donation. What they do instead is that they collect your blood. Some of it gets sent off for testing for disease markers, and they test for ferritin at the same time. And then for those with low or absent iron stores, as measured by the ferritin test, they can recommend a longer interval or recommend iron supplementation. The drawbacks of ferritin is there's no point of care tests, and there's some cost and compliance issues. So, and I wanted to start looking at an alternative approach, which is to personalize the minimum interval. So we can tailor the minimum interval between back-to-back donations to each blood donor's estimated risk to try and target high-risk donors who are at high risk of iron deficiency, and give them a longer interval, but without unduly restricting donations from lower risk donors. So the idea is that we could potentially balance the risk to the donors versus the constant need for blood for donation. The drawbacks are that, of course, it's complex and untested. So in this first paper I did in this area, which was published in Transfusion, we framed this prediction task as a multi-class prediction. So someone gives a donation. Index donation doesn't necessarily mean it's their first donation. We just use index to mean it's the one from which we're making a prediction. And then they come back sometime later, and either they give a donation with no adverse outcomes, or they're deferred for low hemoglobin, or they gave a donation, but we know based on after the fact ferritin testing that they had low or absent iron stores at the time of donation. So I used this data set from this RISE study, which had a lot of rich data that we don't always have for blood donors. So we had donation history, variables, questionnaire responses related to diet, height and weight, whether they're taking iron supplements, and then biomarkers. We have hemoglobin for everyone because you have to get your hemoglobin measured to donate blood. But for a lot of the analyses, we also had ferritin measured as well as soluble transferrin receptor, which is another iron-related body marker. And then body iron is a calculation based on ferritin. So with all of these data available from index donations and the time to return, we predicted no adverse outcome, hemoglobin deferral, low iron donation, or absent iron donation. However, there were some donors in the cohort who came back, completed a donation, but because ferritin wasn't measured at every donation, we don't know for sure whether they had low or absent iron stores. We just know that they completed a donation. So that I classified those as basically having an unknown iron donation as their follow-up outcome. So I took this data set, and in order to train the machine learning model, I used the I used the subset of donations for which we know for sure what happened at that follow-up donation. So I excluded those -1 unknown iron donation from the model development set. But this is kind of because they're missing, we're missing these donations that we don't have the ferritin for. This is going to kind of change the distribution of outcomes from what we really see in real life. So I also have this more representative first return data set, which I also created in pre-processing. So with the model development set, I use nested cross-validation to generate the machine learning model that's uncalibrated. And we use this with this uncalibrated model, we can measure its discriminative performance. So how well can it discriminate between people who are having one of these 4 outcomes? And we also looked at the variable importance. So which of these covariates are most important for informing the risk score? And then I use this first return set with a representative distribution of the outcomes when they come back to calibrate the top model. And with that calibrated model, I generated individual risk trajectories. So for each donor, I can estimate how their risk of adverse outcomes as a function of how long until they return. And then we developed in this paper just a simple tailored algorithm for tailoring the interdonation interval. And then I generated a pretty simple policy simulation. However, I'll talk to you about the ongoing work we're doing to strengthen kind of these 2 parts, the tailored interdonation interval algorithm and the policy simulation. So I used a few different types of machine learning models that tend to work well with tabular data, including gradient boosted decision trees and random forest models. So the nested cross-validation procedure, it's basically a way to get an unbiased out of sample performance estimate that is kind of more conservative with the data than the more traditional, train, validate, test data split. I can give her more details if people have questions about it, but basically you're doing like, the way I implemented it, I used 5-fold cross-validation across 15 tuning sets to select the top model. And then within the inner folds, so the left out data from these 5 folds, I did 3 resamples of 5-fold cross-validation to assess the top configuration. And the top configuration was selected based on area under the ROC curve. Because we have 4 outcomes, we can't use the traditional binary one, but there's this multi-class area under the ROC curve method that uses kind of like a pairwise averaging as a simplistic way of putting it. And we also can assess performance with 1 versus rest area under ROC curve. That's basically, I pick 1 outcome, say a low iron donation, and I see how well the model predicts that one versus the other 3, which tells you kind of which outcomes does it do better at discriminating versus the others. And because we had this rich data set, which included ferritin and soluble transferrin receptor, which are biomarkers not measured at every donation by most, or by any, rather, blood center, I wanted to see whether having these as features or covariates to help make the prediction improved things by a lot or not. So I did 2 versions, one with these as features or covariates and one without them. But ferritin at the follow-up donation was still needed, of course, to classify that follow-up donation as having low or absent iron or not. So here is basically these plots are showing for the top is with the extra biomarkers, the bottom is without. So this turf sign XGB1267 is one configuration of an extreme gradient boosted machine. Each of these 15 dots is the performance on one of our 15 tuning sets. And then I just plotted the distribution and the mean and standard error. And what ended up being the best model for both of these settings was an ensemble model. So a model where you're essentially averaging the base classifiers. So this top ensemble was consisted of these gradient boosted machines, random forest and ElasticNet. And you can see that it did perform better here in blue than the base models in red. And without the extra biomarkers, the ensemble was 3 gradient boosted machines and 3 random forests. And you can see that the ensemble outperforms any of the base models there as well. But that the performance is about 5% better in the area under the ROC curve with the extra biomarkers. And with our out of sample performance estimate, we see that both models are best at discriminating people who have no adverse outcome versus those who are going to have any of these 3 adverse outcomes shown, which you can see because this cyan or blue line is furthest to the upper right. We can see that when we add the extra biomarkers, performance does go up, particularly for predicting absent iron stores shown in red. We see from the table on the right that goes up by 9% AUC in terms of absolute percent, not relative percent. And low iron stores or our low iron donation, that's shown in orange here, and that also goes up by a fair bit, by 7%. And I think it makes sense that those would be the ones that improve the most, because those are defined based on your ferritin level when you return. So having your ferritin level at time 0, it makes sense that would help you predict ferritin level at time whenever they came back, 56 days or more later. In terms of feature importance, without the extra biomarker, the time to return was the most important feature, followed by hemoglobin and number of red blood cell units lost through blood donation in the last 24 months. Excuse me. But when we add ferritin in, that kind of dominates. That's the most important variable by far. Sorry, I got a bit of a cold. So sorry about my voice. In terms of probability calibration, so this is where we take the model development data set, which has no donations with unknown iron status, right? So we because those would be unlabeled, we remove those from the model development data set. But for a more representative picture of the distribution of outcomes at the return donations, we have this first return data set where about a third of the return visits was a completed donation, but we don't know whether the donor had low or absent iron stores. So based on this, we assume that these unknown outcome were distributed proportionally across these hemoglobin deferral, low and absent, sorry, not hemoglobin deferral, the none category, low and absent iron stores. And based on that, we can generate a weight. So we basically take the raw risk scores from the uncalibrated model, we weight them by these weights, and we get our calibrated estimated probability of each outcome. And you can see that we downweight hemoglobin deferrals and we upweight low and absent iron store donations. So here I'm showing you the individual donor risk trajectory. So the first, each of these plots corresponds to a different donor. The x-axis is how many days until they come back, and the height of the colored regions is the estimated risk based on the machine learning model of each of our outcomes. So you can see that this first donor has a pretty high risk of lower absent iron stores if they come back 56 days later, but that risk subsides with time. And the second donor has very low risk of an adverse outcome, even if they came back right at 56 days. And here I'm showing just a random selection of 25 individual donors. You can see a lot of heterogeneity. You can see there's some people who have quite low risk at 56 days, some people with high risk that goes down with time, and then other people like this person here on the in the left row, second from the bottom, who we estimate has a very high risk of absent iron stores, even if they wait 250 days until they come back. And looking at this, we decided to classify the donors based on their trajectory. So we have fast recoverers who have a low risk 56 days later that stays low. We have slow recoverers. So these are people who with a relatively high risk that drops with time. So maybe these are good candidates for a longer interval. But then we have these people who we estimate to be chronically high risk. So these are people, perhaps, a hypothesis is that maybe the model is finding people with underlying iron deficiency that is not caused by blood donation. And these people perhaps should not be good candidates for blood donation in the first place. So taking this further, we wanted to develop a decision rule to tailor the interdonation interval. So basically what we do is we identify the time that the minimum time such that the risk of each of our 3 adverse outcomes, low iron donation, absent iron donation, or hemoglobin deferral, is below some predefined threshold that we define separately for each of the 3 adverse outcomes. So we can say, this is the maximum risk we tolerate for each of the 3 outcomes, and we can just wait until the donor's risk is below all of those for that day and all days into the future. Now, the reason we have to make it a little bit more complicated, and that the risk is lower on that day and all days into the future, is that for low iron donations, the risk can actually increase with time, which might seem a little counterintuitive, but let me go back to this slide. But what you see, so let's look at this person in the far right middle. This orange is the low iron donation. You can see from day 56 to about day, let's say 80, it's growing. And that's because people with absent iron stores, their ferritin rises, they become low iron stores before they become, before they have, normal iron stores and go to the no adverse event category. And similarly, people who are deferred for low hemoglobin, as their hemoglobin recovers, they might have low iron stores before they transition into having no issue. So that's that's an interesting thing that we found. And that's why we defined this decision rule, where we had to focus on the subsequent days to make sure the risk doesn't increase above our threshold in the future. And then to simulate what this policy would look like, we chose 3 different other countries that have similar blood collection systems, but a longer interval. So the United States has 8 weeks or 56 days for men and women. Canada has 84 days for women and 56 days for men as the minimum interval. Australia is 84 days for everyone. And the United Kingdom has 112 days for women and 84 days for men. So they're the most conservative. And we simulated, well, in the simulation, we estimate how many donations would be collected per 100 donors per year, and the number of adverse outcomes per collected donation. And this is an oversimplified model, and it's very specific to the RISE donors, which is a study cohort was donating more frequently than typical. So these won't necessarily extrapolate directly to a more typical donor population. But with those caveats, here's what we found. Basically, for each of the alternative policies from another country, we can find a tailored policy defined by 3 thresholds. So this one that we paired with Canada has a 20% maximum maximum allowable risk for hemoglobin deferrals, 50% limit for low iron donations, and 40% limit for absent iron donations. And we see that we get a smaller drop in collections versus the status quo US policy, and a much bigger drop in hemoglobin deferrals and in absent iron donations, but actually a slight increase in low iron donations, which is due to that mechanism I was talking about before. And you can see that for each of these, the Australian and the UK policy as well, we can develop a tailored policy with different set of thresholds where we get that slightly better drop in collections, but much better loss of or reduction in hemoglobin deferrals and absent iron donations. So this is basically where work I started during my PhD, and I got funding from the AABB Foundation to extend this work. So I'm now working with collaborators and data sets from Vitalant in the United States, SANBIS, which is the blood collector in South Africa, and Sanquin, which is the Dutch blood collector, to externally validate prediction models, assess alternatives to a fully tailored approach. So in the machine learning model, we assume probably would do the best but it might be complicated, or people might not have concerns about a machine learning model that's kind of black box. So can we assess simpler policy changes? And can we build a better model to simulate donor return dynamics to estimate the impact of policy changes? So basically the RISE study is what I used in this initial paper, but we've got much larger data sets from Vitalant, SANBIS, and Sanquin. And so here's some preliminary results done by my PhD student, Chen-Yang Su. Interestingly enough, we found that predicting ferritin, we do pretty well in the Vitalant data. With 10%, we did basically 10% worse with ferritin as a covariate. We actually did slightly better when we have hemoglobin only, and a bit worse in both South Africa and the Netherlands. And then when we're predicting hemoglobin, adding ferritin as a covariate doesn't actually improve things too much in the RISE data set, but it does a lot better on the Vitalant data set. I do think we need to do some subgroup analysis to investigate this further, but the hypothesis is that the improvement in Vitalant data set is probably because some of the groups that are hard to predict are overrepresented in the RISE data set, but subgroup analysis will hopefully reveal if that's the case. But interestingly enough, we do pretty well externally validated to both the US and South Africa when it comes to predicting hemoglobin with ferritin as a covariate. So pretty good external validation results all in all. And another thing we're working on is trying to get a better understanding of donor return dynamics in order to enable us to do a better simulation model to assess policy. So master student Huzba, who's pictured here, she created this plot. But we know that in particular, mobile blood sites or mobile blood drives might have challenges when you start to change the interdonation interval or personalize it, because people who come to a fixed collection sites, if you tell them to come a week later, they can come a week later. If someone goes to a mobile blood drive and the drive's not going to be there in a week, then they won't necessarily come back as soon. So we're trying to do a better job of understanding the return patterns between mobile and fixed collection sites, so that we can understand donor return behavior in a way that will allow us to simulate policy changes. And here you can just see that donors who are basically loyal to a fixed collection site came back a lot more than donors who are loyal to a mobile collection site. And the approach that we're working on taking here is that basically it's kind of a nested prediction model approach. So the Huzba's already developed this penalized Cox model that can take the covariates from a visit, like about the individual and where they were donating, and simulate the estimated time until they come back for their next donation. And then both those covariates and the time to return are used as covariates for predicting the outcome when they return. So the idea is that we can create a discrete event simulation that basically has under the hood these kind of nested data-driven prediction models in order to do a better job of to create a model that can really be used for decision analysis in terms of things like changing the interdonation interval, or even other changes like changing the hemoglobin threshold or other deferral policies. So the main takeaways from this analysis are that we can develop and assess more personalized approaches to managing iron deficiency and repeat blood donors by combining machine learning models that predict time to iron recovery and the trajectory of adverse outcomes, optimization-based decision rules that balance operational objectives, the constant need for blood, and health objectives, and simulation models that estimate the operational and health impact of different policies to help us, a blood center, decide what to do in silico before piloting or implementing any changes. I'm happy just to pause here if people have questions, or I can also keep going. I don't see any in the Q&A.
No, there's no question yet, so I'd suggest to proceed to the next section.
All right, so next I'm going to move to a totally different topic or application area, which is targeting overdose prevention for prescription opioid patients. So this is work that I began during my postdoc and was supported by and in collaboration with actually the FDA. But due to some delays in getting the data, I couldn't do the data-driven modeling part until after I started my position at McGill. So I've been trying to hack away at it when I have the time. So naloxone, is often more commonly known by Narcan, which is the brand name of the nasal spray form of it, is a drug that reverses opioid overdoses. And take-home naloxone is very effective for reversing an opioid when it's witnessed and recognized. So basically, it's in most cases someone else has to administer the naloxone to the person overdosing. So there has to be another person there. They have to know where the naloxone is and how to use it. But when it's used, it is very close to 100% effective at reversing overdose. And there's been cost effectiveness analyses that found that it's cost saving for people using illicit opioids. And currently in the United States, there's a lot of heterogeneity, but about 17, I believe it's 17 states have implemented some kind of mandate for prescribing naloxone alongside prescription opioids in certain cases. And those certain cases are hugely variable from state to state. Some is based on the dosage, the duration, comorbidities, other drugs that are co-prescribed that might have an interaction risk. And the question is dispensing naloxone with prescription opioids effective and efficient, and for which opioid patients? So we got data literally the day before my postdoc ended, from IQVIA, which has data from multiple payers. In the United States, that's a really nice thing because, in Canada, you can go to the province and get all of the data that covers almost everyone. In the United States, there's so many different healthcare payers. So a multi-payer data set is a nice thing to find in the United States. But anyway, we've got data from many payers on all of the drugs dispensed to the patients who received opioid. The cohort's defined by having been dispensed opioid analgesics. And we use the drug data to construct opioid episodes and identify risk indicator drugs, because we wanted to look at targeting naloxone. So we wanted to look at not only opioids, but other drugs that people receiving opioids might have received that might indicate some risk of overdose. We have diagnosis data. So we have all diagnoses for the linked patients, which we can use to identify both diagnosed overdoses, opioid overdoses, but we can also identify different diagnoses that can be used as a risk indicator. And then we have age, sex, and race as demographic data. So the strength of this is it's a large multi-payer data set. The biggest limitation in terms of our analysis is that there's no data on death, including fatal overdoses. So, in Canada, because everything's kind of maintained at the province level, you can often get linked vital statistics data relatively easy, where you can get deaths and cause of death, but it's more difficult when you're using claims data in the United States. So kind of an overview of the methods. We constructed opioid episodes and then selected our cohort and classified people as having or not having different risk indicators, and analyzed the overdose rate according to risk indicators. This first row is what I call the cohort analysis. And then we did the policy simulation. So in order to do that, we developed a model to predict diagnosed overdoses, because that's what we have in the data. And then we use this and some other things and some other estimates from the literature to impute undiagnosed fatal overdoses. And I'll talk more about this in a few slides. But once we've imputed fatal overdoses, we simulate outcomes with naloxone, where we assume that naloxone would have prevented some, but not all of those fatal overdoses. And then we can analyze the distributional impact, so how the policies would impact different groups. In terms of constructing the opioid episode, an episode is a series of opioid prescriptions without a gap of more than 30 days in supply. Sometimes people get prescriptions with overlapping supplies, and we basically assume that they are carrying that medication over. And so we're using that as part of the episode. When we constructed the cohort, we actually started with about 48 million individuals, because this data set was larger than just the opioid patients in the time period that we were looking at. But we removed some patients due to data issues. And we also focused on just the cohort for whom we had complete information on age, gender, and race or ethnicity. And we filtered down to the time period we were interested in. We made sure that they had diagnosis data. And we only used the first episode per person. And we also filtered out for the cost effectiveness analysis, we excluded people who were not dispensed naloxone. So in the cohort analysis, we looked at the rate of naloxone co-dispensing, but for the cost effectiveness, we were to estimate the cost effectiveness of giving naloxone to people who did not have it in the base case, or like in the actual data. So for some definitions for the diagnosis or drug-based risk indicators, we considered them if they'd started in the 2-year period before the start of the episode. We looked at, when we were looking at the rate of naloxone being co-dispensed for the cohort analysis, that we consider that being any time between in the 2-year period before the episode started and when the episode ended. This is based on, there's a recent paper that showed that naloxone's shelf life is at least 2 years. So we chose 2 years as kind of our period. And then the outcome that we're looking at is opioid overdose anytime in between episode start and 2 years after the episode starts. And because the policy we simulate is going to be giving them naloxone at the start of the episode, And we assume that it has some chance of preventing an overdose anytime in the 2-year period after the start of the episode. We identified risk indicators with based on diagnosis related to mental health, nicotine dependence, other substance use, which includes opioids and alcohol. Severe mental health, which we broke out. These are things like bipolar disorder or psychosis conditions, dementia, a history of overdose, right, and opioid overdose, which we actually lumped in. So if you had an opioid overdose before your opioid episode started, you would be lumped in with this overdose category. And then in terms of the prescription risk indicators, you can actually ignore this persistent and interaction risk because we ended up kind of simplifying and getting rid of it. But you can just see here, there's a large number of drugs that we considered, including medications for opioid use disorder, and a lot of drugs that might be associated with a mental health condition or have a interaction risk. And we also considered a high dose, so which we consider to be over 20 daily morphine milligram equivalents. So within the opioid kind of research community, there's people have basically converted all kinds of opioids other than morphines into the equivalent of a milligram of liquid morphine as a way to kind of have a quantitative measure of the dosage that's comparable. So here I'm showing you basically the results of the cohort analysis. So out of our almost 4 million patients, overall, we had about 5 diagnosed overdose per 10,000, and 1% of them received naloxone in the data. And then looking at the drug-based risk indicators, I've sorted them according to the diagnosed overdose rate. So medications for opioid use disorder is this MOUD, which had by far the highest rate of overdoses. It's only 2.6% of the episodes. And about 6 or 7% of them in the base case did receive naloxone. But interestingly enough, you see that high dose opioids and long-term opioids, so this is an opioid episode lasting at least 90 days, those had the highest risk indicators, had the highest percent receiving naloxone, and they had certainly a much higher risk of overdose compared to the overall cohort, but they weren't, they're not as high as things like medications for opioid use disorder or prazosin, which is a drug that is has multiple uses, but one of them is PTSD. In terms of the diagnosis codes, you can see that substance use had the highest rate of diagnosed overdose, and then severe mental health was behind it, and about 6.7% of the people with substance use diagnosis received naloxone. And there's of course going to be overlap between this group receiving medications for opioid use disorder and the group with the substance use related diagnosis. In terms of imputing fatal overdoses, so how I did this was I took calibration targets from the literature, and those are related to the total number of fatal overdoses. So this is from basically studies where we had linked data. So they have data from, say, like a prescription drug monitoring program. So a lot of states have these programs to monitor who's getting what drugs for drugs like opioids, where there's concern of abuse. And they've been able to link them to vital statistics data and estimate overdose rates. And then the ratio of fatal to non-fatal overdose was another calibration target I defined from the literature. And then I developed a predictive model to estimate the distribution of the fatal overdoses across the groups. And the key assumption of this, the model is actually predicting diagnosed overdoses because that's what we have in the data set. And we're making this assumption that the risk factors associated with unobserved fatal overdoses and diagnosed overdoses are the same, which I think is probably a fairly safe assumption. There might be some group that's disproportionately not, maybe that's not having a diagnosed overdose because they're not seeking care, but hopefully it's not too big of a factor. That is one limitation of the paper because we don't have the vital statistics data. And I use a random forest machine learning model using age, sex, race, and all those risk indicators and the episode duration as covariates or features for the prediction. So here's the result of predicting the diagnosed overdose. They had an area under the ROC curve of 82%. Here you can see the density of the people for whom we predicted they are the people of the risk score. So the risk score is on the x-axis. So a higher risk score means the model thinks you're more likely to have an overdose. And then these kind of density plots are showing you this is the distribution of the people who did have an overdose. And you kind of see this bi-middle distribution. So some of the people who actually had an overdose had things in the data the model picked up on is clearly indicating a higher risk. And then other people, maybe there's nothing in their data indicating their risk, because we only have data from kind of healthcare interactions. So we don't know everything about the person. So anyway, I think that this suggests that it's a reasonable model. In terms of the things predicting, the things associated with a higher risk, a history of opioid overdose is number one, followed by medications for abuse disorder, a substance use diagnosis, and prazosin. So they're quite similar to the things on the prior slide that were associated with the overdose rate, which makes sense. In terms of imputing undiagnosed overdoses, I'm actually redoing the calibration because we got some newer data that wasn't published when I first ran this. But here I'm showing this is the prior distribution. I use a Bayesian calibration procedure. So you set a very uninformed prior, which is a uniform distribution on both the two parameters we're calibrating, which is the probability of fatal overdose and the ratio of fatal to non-fatal overdose. And you can see that the posterior is kind of, it's still a fair bit of uncertainty, but it's certainly, we learned something. It's not as wide as the prior, and there's some correlation between these two covariates, which is what this lower left plot is showing. For the policy simulation model, we assume that naloxone can avert a fatal overdose within 2 years of when it's dispensed, and we're assuming it's dispensed at the start of the episode. We assume that there's a lot of uncertainty in kind of how much it'll be used. Unfortunately, there's not much data where we give naloxone to patients receiving prescription opioids and then actually follow up to see whether they use it or not. There's basically nothing out there. So that's why these uncertainty ranges are so wide. But for it to be used, there has to be a witnessed overdose. The naloxone has to still be available, so it can't be lost, and the bystander has to actually use it. If it's used, we assumed some uncertainty in whether it prevents fatal overdose. This uncertainty is not so much due to uncertainty in whether naloxone is effective, but more whether it would be used correctly. And whether if the patient doesn't seek care, this doesn't have any impact on the main outcome, which is averted fatal overdose, but it does have some implications in terms of our costs. So health economic outcomes, we use a societal perspective. So we included productivity impacts of both fatal and non-fatal overdoses. We included for a non-fatal overdose, a healthcare cost, a loss of some quality of life days and some productivity. Again, there wasn't very much in the literature for actual quality loss due to non-fatal overdoses. But it doesn't matter that much for our analysis because the real benefit is preventing the fatal overdoses. If a fatal overdose occurs, we assume that the person will lose their remaining quality of life years, which are based on their age, and the loss of remaining lifetime net productivity. So here are some preliminary results. Again, I'm recalibrating the model and changing some things, but the basic idea is that to give naloxone to everyone prescribed prescription opioids, it likely would not be cost saving, but it might be cost effective at maybe $100,000 per quality just life year or so. But if you look at these like MOUD or prazosin, we estimated in this initial preliminary pass that it might be very cost effective and in fact cost saving. So basically the savings you get by averting those deaths and those productivity losses exceed the cost of the naloxone. And that's true for the diagnoses that are quite predictive. So anyway, this is still a bit of a work in progress, but I think the main takeaways we can say at this point are that combining methods, first of all, I think when you combine methods from epidemiology, machine learning, and decision modeling, we can develop an analysis that can inform targeted overdose prevention. You know, there's all this heterogeneity right now in the United States in terms of what states say what about who should get naloxone. And by the way, those states that have these mandates, not that many people are actually getting the naloxone in the first place. But I think so. I think this set of methods can shed some light on kind of where to go for policymakers. I think it's pretty, even though I'm going to recalibrate the model and things might change, I think it's quite clear naloxone is going to be cost effective for patients with certain risk indicators like substance use disorder or medications for opioid use disorder. There is a lot of uncertainty, and it could be reduced if we had better data on naloxone utilization for this population of patients prescribed opioids. We have some for the patients who are using illicit opioids, but again, it's a different population. And if we had linked data on fatal overdoses, I think a big limitation of this analysis was my focus on, I only modeled giving naloxone at the start of the episode, but in reality, you'd like to be able to give naloxone in the middle of the episode if it's triggered by a risk covariate. And if we had linked data on fatal overdoses, that would be much more feasible to do. So I realized I went a bit over the time, so I'm going to be very brief on the emerging research areas. Just to say, I was part of this the State of the Science and Transfusion Medicine working group that focused on new methods in transfusion science. This is setting priorities for the National Institutes of Health, or National Institute of Heart, Lung, and Blood, National Heart, Lung, and Blood Institute, which is one of the National Institutes of Health in the United States. And I proposed one of the focus areas would be using data-driven approaches to improve the accuracy and applicability of economic evaluations for blood banking and transfusion medicine. And it made the cut. So this was identified as one of the top 5 research priorities in terms of new methods in transfusion science. I think that synthetic data would be a good way to enable this, because the challenge is if you build economic evaluation using patient level data, you can do a whole lot of things. You can get a lot more granular. You can understand how subgroups are impacted differentially, but you can't share those data in most cases publicly. You have data use agreements that prevent that. So one of my future research areas that I would like to do is to generate, I'll start with blood safety or transfusion recipient safety, but take the data set and use something like a Bayesian network to generate a synthetic data set. So these are simulated patients, they're not real patients, but their distribution, and rather the joint distribution of the characteristics, look like the real data. And that's something that you can make public, and other researchers who want to build a simulation model to assess a different type of policy that might affect risks to transfusion recipients can take your synthetic data without having any data use agreement and build their own model. So that's one of the areas I want to go into. Another area I think is the integration with forecasting models. So at least when it comes to transfusion safety, all of the cost effectiveness analyses have been done with retrospective data. So we can say, in the last year, in the last 2 years, was it cost effective to screen the blood supply for this disease or not, or to do this policy or not? But of course, blood centers or regulators care about the future risk. And I want to use West Nile virus as kind of the first place to focus to try and take different surveillance data streams. Because West Nile is transmitted, basically birds carry it into new areas, then mosquitoes take it from the birds and infect people and animals. There's also all kinds of weather and seasonal factors that influence its spread. So can we build a really good risk model for West Nile virus and then use this to guide when we start and stop seasonal screening for West Nile virus each year? So the overall vision I have for data-driven decision modeling, I think that today decision models can sometimes struggle to reflect subgroup heterogeneity, and these kind of mathematical models that we have traditionally used don't always allow for a lot of heterogeneity. And then just data scientists have great methods for heterogeneity, but their analyses are not optimized for informing decisions. So my hope is to kind of develop and utilize a suite of methods that can integrate data-driven and decision modeling methods to inform targeted interventions and enable equitable policymaking for heterogeneous populations. So I want to thank my collaborators, my trainees at McGill, and my funders, and I'm happy to take your questions.
Okay, thank you, Dr. Russell. So we'll now invite attendees to use the Q&A function in the Zoom software menu. And then anyone with further questions today after today's webinar is encouraged to email noah@ihe.ca. So I'm just looking, and it looks like we're still waiting for some questions to come in. So I think I'm going to start with some of my own. So I think this is so interesting to be using the administrative patient level data, populating the decision analytic model with it, and then using that decision analytic model populated with the admin data to produce the outputs. So, but I'm wondering, usually in decision analytic modeling, you would kind of take estimates from the literature that are kind of vetted. We kind of know what to expect. There's ordinal properties to these different relationships. Have you run into the issue where the admin data or your patient level data doesn't quite match up to what you're expecting?
That's a good question. So thus far, for these two projects, I think that what we found in the data was either expected. I think in terms of which people had the highest overdose risk or which covariates were associated with basically having low hemoglobin deferral or lower absent iron when someone returned. Those were pretty much what we expected. The only surprise I would say was I was surprised that over time the risk of low iron donations could increase but when I presented, I was surprised when I presented it to my kind of collaborator who's a domain expert working in this space for much longer than I have. He's like, oh, that makes sense for the mechanism that I kind of explained. So thus far, nothing has been too out of sync. But yeah, I think that it is always good to kind of check what you find against literature reports, because if you do find something that doesn't match up, either you discovered something really interesting or there's maybe some mistake somewhere, either with the data generating process or your own analysis. So I think it's always good, even if you are relying on your own data set and not literature for some of your model parameters, I think it's still a good idea to go and look at the literature and kind of vet or validate. It's a way to kind of to validate that what you're finding in your data set makes sense.
All right, thank you. So we're still waiting for people to add to the Q&A. Please go ahead if you have a question. Otherwise, we will all be listening to my questions for the full Q&A. So another question, I guess, is, so when you're working on these models, there's so many different moving parts. Do you kind of chop these into different pieces for publication? Like when you kind of do the machine learning model, publish that as a standalone, or is it complicated to try and publish papers with all of these integrated methods?
Yeah, that's a good question. So currently so I guess for the first project, the only paper I published of that kind of was the machine learning. So the main focus was generating the individual risk trajectories. So I published a machine learning paper only on that. The simple the policy simulation that I did in that paper, I didn't publish because it's quite simple and that population is kind of so biased. So the idea of when I got to McGill and I was going to write, I wanted to expand to operational data sets rather than that was a study data set where they oversampled young women in particular, because that's a population we're concerned about iron deficiency in. And they asked people to donate quite frequently. So I didn't think it was worth publishing a policy simulation on this very biased study sample. But now that we have this operational data, we're working on building a better simulation model that will publish. And the approach for that too, we're breaking it into pieces. So my master's student Huzba, I showed kind of that Kaplan-Meier curve she did. She's done that in a Kaplan-Meier model, and that's going to be her first paper, which we're hoping to wrap up this summer. And then in her second year of her master's, we're going to hopefully get into the actual simulation model. So again, it's kind of data-driven modeling paper first, and then a policy simulation. Yeah.
Okay. Well, that makes a lot of sense, and kind of better to separate it than trying to do too much all with one paper.
Yeah, particularly if you have insights from the data-driven modeling that can stand alone and contribute to literature without the simulation model, then I think it makes a lot of sense.
For sure. Okay, so one other question is, could you speak a little bit more about the pros and cons of this type of data-driven decision analysis, comparing Canada to the US or other countries?
Yeah, so this work I presented was, US mainly, and then I talked a little bit about the external validation to South Africa and the Netherlands. I've started some stuff in this area here in Canada, but it's all early. I think that Canada actually, particularly when it comes to if you want to do individualized, or if you want to use the data-driven methods to inform equity, Canada has a big leg up in that within each province, you have data that covers very nearly everyone. In the United States, there's so many different payers. It's difficult to get data that's truly representative. And then also in Canada, I mean, like if you want, for any given health condition, you can get data at the province level in Canada. It might take a bit of time. And of course, there's data use agreements and some costs, but you can get data for everyone with that health condition in the province. And you can get linked data on deaths. So, and other things, right? And you can get neighborhood level data on like material and social deprivation. So I'm learning that the data process in Canada can be slow, but that there is richer data. The only place where I would say the data is less rich in Canada is when it comes to race and ethnicity, because Canadian administrative and clinical data sets don't capture race and ethnicity. But otherwise, I think Canada actually has a big advantage when it comes to this kind of work in terms of linked administrative and clinical data that can enable this kind of thing.
Thanks, it's interesting, kind of exciting for those of us in Canada. So we have one question from Dr. Matthew Yama, who is our Director of Economics at IHE. She would like to know what the appetite is among policymakers for the use of machine learning for policy studies.
Yeah, I guess, I haven't quite gotten to the point of presenting anything with anything that's integrating machine learning and decision analysis to a policymaker. I did, like during my PhD, I published a paper about the cost effectiveness analysis of screening the blood supply for Zika virus. And then the advisory committee to the FDA that talks about blood safety policies met shortly after, and I submitted comment to them, and that was it was a simulation model, but there was no machine learning component. But what I kind of found was that that set of policymakers were they just focused, they kind of discounted the evidence, and generally they didn't look under the hood at all. Like they only looked at like the main findings of the abstract. And they even said in that meeting that there was no model estimating the risk of Zika. But of course, in order to develop the model to estimate the cost effectiveness of screening for Zika, embedded in that is a model estimating the risk, because you can't estimate the cost effectiveness if you don't have an estimate of the risk. So that was not the best experience with the FDA, because my postdoc project was more collaborative. And of course, because of the timing, I didn't get to present any of the machine learning results during the postdoc, but I kind of met with the FDA 2 or 3 times after my postdoc ended. And they seemed pretty receptive. I think particularly when you show them like the variable importance plot, and like it kind of like it makes sense. It kind of lines up with. So I think if you can kind of show like what the machine learning model is kind of doing a little bit, then I think that they can be receptive. At least the people who care to learn the methods. Some policymakers just don't care, I think. Yeah.
No, that makes sense. Okay, so thank you again, Dr. Russell, for your presentation, and thanks again to everyone online for attending. So today's seminar was the last of this academic calendar year, so please visit NOAHE.ca to subscribe to our mailing list and to get fall event announcements. Thanks again, Dr. Russell.
Great. Thank you, Aaron. Thanks, everyone. Have a great afternoon.
Bye.